front of you today to provide our general data update, let you know what's going on. We're at another pivot point here in our work with COVID-19. So just want to provide you a level set of what we're beginning to see as we enter the school year. And also just our general data in terms of trends, case positivity and hospitalizations, but then also some updates on our vaccination uptake across the county. And with that, I'm going to turn it over to Dr. Vines.
Great, thanks, Jessica. Good morning, Chair Kafour. Good morning, Commissioners. Great to be with you. For anyone who's listening, this is Jennifer Vines, Multnomah County Health Officer. I'm going to take you through some familiar slides, but I think this helps ground us in terms of where we are. This is just number of cases over time, and this is only the 2021 calendar year as you look from left to right. So you see that you see how our current wave of COVID compares to some of our other big waves. So last January and then in the spring, you see we're much higher just in terms of cases. You will notice that these are just all cases. And so anywhere from 20 to 40% of these cases are breakthrough cases, which means they're in someone who've been fully vaccinated. And I'll talk a little bit more about that during my time with you today. You also see that white cases among white people are above Black, Indigenous, and people of color. But we do know that Black, African American, Alaska Native, Indigenous, and Hispanic remain disproportionately affected. So just these lump categories hide some disparities that I'll also touch on in our conversation this morning. Next slide, please. This is our test percent positivity. So again, this takes into account the number of tests that we're doing versus how many are positive. So one point of good news is that you see the volume of testing, that's those blue bars, again, looking since January 2021. You see that volume of testing has gone up. That's good news. I don't think anyone in public health thinks it's at a level that it should be to meet full demand, but it's certainly better than it was. You see us sort of in a rocky plateau right now, similar to overall cases. We're still in that danger zone between 5 and 10% of test positivity. We track very close to Washington County, and Clackamas County tracks a little bit higher than we do on percent positivity. There are several Oregon counties that are over 10% positivity, well into the danger zone. The caveat there being that smaller numbers make those percentages a little bit more erratic. So we remain on alert. There might be some good news in terms of the trend, but we remain kind of at a plateau again in the warning zone. Next slide, please. This is, of course, what we care about the most in addition to keeping kids in school, and that's how our hospitals and health systems are doing. This is just Multnomah County hospitalizations. The general sense during the Delta predominance phase of this pandemic is that patients are younger and sicker and stay longer. There's good evidence for that, at least for adults over age 18. If you take your eye along the yellow bar, I've called your attention to this before, that's Black, African American, and African immigrant and refugee cases. You see how that black bar sort of expands in April when we first were alerted to an increase in hospitalizations despite widespread availability of vaccine. You see it track again, sort of widening again in August. So really a disproportionate increase in spring and summer that has prompted a very focused response through our REACH program, low barrier vaccine clinics, and really specialized messaging. And I think an important reminder that as we increasingly sort the world into vaccinated and unvaccinated, there are lots of different reasons that people are not yet vaccinated. And so we need to keep that in mind as we think about communities that have had poor experiences, to say the best, about as far as their interactions with medicine and public health. Next slide, please. It's really awesome to get the chance to highlight some local science. So our communicable disease team includes epidemiologists, some really, really smart ones, who have published a study based on our local data about vaccine effectiveness in a really nice little study design comparing June 2021 to July 2021. So that was kind of the watershed moment of very little Delta in June and then mostly Delta in July. They looked at people who had tested positive and who had tested negative, and then did a look back to see if they were fully vaccinated. And you can see they looked at a nice number of people, so 600 in June and 1,000 in July. Bottom line is that we are seeing more breakthrough cases. So this is just purely whether you would test positive, not necessarily if you're going to go on to be hospitalized. But we see 40% of cases over age 16 vaccine breakthrough. That's expected as we get more and more people vaccinated. More and more of our cases will be vaccine breakthrough. Good news is that if you are vaccinated, you're half as likely to be hospitalized. And they really concluded that there's no evidence of waning immunity here. So when we talk about waning immunity, that means, is your body forgetting what the COVID virus looks like? And is it forgetting how to generate that full immune response? So not just antibodies, but all the cascading fighter cells that we have in our bodies that keep us from getting severely ill. And the answer is largely no. So, we have a 90% vaccine effectiveness rate in June. That was amazing. We all felt that as we went into lifting restrictions. It went down to 75% in July. The bottom line is really that it went from excellent to really good. So that's still really reassuring. And if you go to the next slide, this is my last one. These were just some of their conclusions. So yes, so 90% to 75% vaccine effectiveness is a drop, again, from excellent to pretty good. We think this is from the Delta variant's ability to get around the vaccines, or at least the front line of our immune responses, as opposed to our bodies kind of forgetting what the virus looks like and losing its ability to fight it. And this has some implications, and you see this playing out nationally with the debate about approval for boosters. So it's not clear that getting another shot of vaccine designed for the pre-Delta virus is going to do a whole lot to boost your protection. Rather, we're probably better off focusing on those who remain unvaccinated, and with vaccine approval potentially coming online later this calendar year for under age 12. Maybe down to age 5 or 6, there's an opportunity there, I think, for more primary prevention. So I think that's the end of my piece, and I believe Jessica is up next to talk about vaccines more.
Thank you, Dr. Vines.
Can we pause for a moment and have some questions? That was very informative, Dr. Vines. All right, commissioners. Commissioner Myron, did you have questions?
Yeah, thank you. I had a couple of questions. One was just around testing, and I know with an increasing number of tests available at home, and there's different kinds of tests that are available at home. Do you have any sense of how that sort of fits into the whole testing process? So whether maybe fewer people are getting tested, but they're tested at home, or more are getting tested because they want to confirm their at-home test results, or whether we can track any of that. How does that play into the whole testing question?
Yeah, so I'll take a stab at that, Commissioner Myron. I think at-home testing is a great low barrier resource for people. The problem is we in public health don't have eyes on those test results, positive or negative. If we hear about them, we actually ask people to confirm it with an official test. But assuming that many people don't go that route, we still make sure to give them all the guidance we would if we had a confirmed positive in front of us. And I know we have Lisa Ferguson, who's very well versed in this, and Jessica. I don't know if you have more to add.
Yeah, you're exactly right. And I think, hi, Lisa Ferguson, Communicable Disease Manager. Thank you. And I think we do, you're right, Jen, that we don't necessarily have an eye on those tests. We do encourage people to get a confirmatory test if they call us and let us know. For school purposes, if they hear about somebody who has an at-home test, they are accepting that as a positive result so that we don't have kids coming into school waiting for a confirmatory test. So there are certainly situations where we accept that result, but officially in our system to be a positive case, we do have to have that laboratory result. And I don't think we fully have a picture then of what that means for the testing landscape, but I do know that's something that is being taken into consideration, especially with modeling as well, to try to understand that a little bit better.
That's super helpful. Thank you. And I had two more questions. One is around that the study, which is super interesting, and going back to those results, and we talked about who were the people chosen to be in that study? Like, how were they selected? And were people that were positive, like they all had symptoms? Were they all they received the same vaccine? Just a little bit more about the study and those findings.
It's a great question. I may have to follow up with you offline, Commissioner, to get the exact details right. But just so people know, the basic idea was pairing someone who tested positive with someone who tested negative at about the same point in time, I believe from the same zip code. So trying to really match for other things in play. And then going back and looking, were they fully vaccinated? I don't think we parsed by vaccine. Our region is very Pfizer heavy relative to Moderna and Johnson & Johnson. I don't know if they parsed it by vaccine type, but I'm happy to get you more on the methods.
Okay. Yeah, no, I'd love to kind of dive into the study. So that would be excellent. And then I don't know if this may be something you'll talk about later. This is something that sort of came up in I think it was an Oregonian article over the weekend about the death rate of people who have been fully vaccinated. It is what it sounds like, and that it had gone, I think it was from ridiculously low percentage, like it was like 0.9% or something, to something like 24% of the deaths were in people who were vaccinated between July and August or something. I don't know the exact numbers, but it was a dramatic increase, and that was from the OHA. This was the sort of the statewide data. And it really didn't make sense to me, and I wasn't sure where to find the information. And I'm wondering if you have any just sort of thoughts on that, or data or information that could clarify that strange, concerning result.
I do, Commissioner. I have quickly put my hands on the Oregon Health Authority Breakthrough Report. I'm looking at deaths just on a graph. They are pretty low despite the total number of cases. I'm happy to send this to you as a reference.
Okay, that would be great. Something didn't add up from that, and I just would want to be able to understand more what might be happening. But I think that's it for me.
Commissioner Dryball.
Thank you, Chair. Thank you, Jessica and Dr. Vines. Just one question about the study, which is super exciting. Congratulations to the folks who worked on that. That's really, really great. But wanted to understand better the difference between escaping vaccine and waning immunity, and then how that takes us to the implication that booster dosing might not provide increased protection.
I will do my best, Commissioner. And our team will be very excited at your interest in their methods and thrilled to follow up with you. So a couple of comments. So the Delta variant is really contagious, and it's really good at making copies of itself quickly in your nose and throat. Typically, the first line of defense from a vaccine is your antibodies. And so there's a lot of talk about antibody levels, and that's like your infantry. So we measure antibody levels. They tell us some things, but they don't tell us everything, because there's a whole beautiful cascade in your immune system of cells that really mobilize to protect you that take them about 24 to 48 hours. So you can have been vaccinated, you can get the Delta virus in your nose. And the first thing I want to say is that our numbers suggest that 75% of people will not go on to have an infection. That's still amazing and really reassuring. And very few will go on to have severe disease. So as the Delta virus goes into your nose, if you have waning antibodies, which we all do, our antibodies are not designed to hang around forever. Otherwise, our blood would be too thick to circulate in our veins. So antibodies will wind down. So Delta variant, it comes in fast and furious. It may be that our antibodies have started to naturally come down, but all those other vaccine-stimulated immune system responses are mobilizing. And they're mobilizing well enough to keep that Delta variant from getting into our lungs and causing pneumonia and making us really severely ill. So the vaccine itself still does what a vaccine is designed to do, which is to keep us from getting seriously ill. Not all vaccines are designed to keep us from being potentially infectious or infected, if that makes sense. So the vaccine itself is still very strong. So some would argue that you can use a booster to try to boost that antibody level, but all those other immune functions are still holding up really well against the Delta variant, and you're better off getting unvaccinated people those protections than you are at trying to tune up or boost those antibody responses in people vaccinated 6 to 8 months ago. So I don't know if that's helpful. I will say this is not a black and white issue. I think we do have an interest in making sure certainly that people who are immunosuppressed get their third dose. That is really important to get their immune systems as up and running as others in terms of protection. I think we do have an interest in making sure that people who are very frail and living in long-term care facilities, we don't want to find out after the fact that they needed a booster. So I think we do need to be paying attention to certain populations. It looks like the regulatory environment is headed that way. But in general, the notion of a booster suggests that somehow our bodies are forgetting their immunity after 8 months, and they're not. We're having a natural tapering of our antibodies.
Thank you. That was helpful. And, intuitively, the question of whether to prioritize boosters over getting unvaccinated people vaccinated, logically, it seems clear to me that in a world of restricted availability of vaccine, we need to bring everybody up to a certain base level. And then, as you say, protect those who are particularly at risk rather than third dose for everyone. But the science is interesting. So thank you for explaining that.
Commissioner Vicki Peterson.
Thank you, Chair. Thank you, Dr. Vines and Jessica. I think that Dr. Vines, you actually touched on what was going to be my question, was just to talk a little bit about the difference between like the booster that's being talked about right now as like a potential, if it's needed or not, depending on the population, and really that third shot for immunocompromised people who need it because they aren't getting that reaction from the first vaccines, and just like the differences there. Because I have some folks who I know who need to have that third vaccine just because of their body's response. Can you just talk about that for a little bit?
Yes, thank you, Commissioner Vega-Peterson. I love this topic because words are important here. So for people who are seriously immunosuppressed, so they've had an organ transplant or they take very high-powered medicine for a serious autoimmune problem, they need a third dose. So their recommended COVID series is 2 doses and a third dose in order to try to get their immune systems to respond and get them some protection. The booster that we're talking about nationally now is a third dose, but for people who are expected to have already had a decent response to the first and second dose and who, we're still debating the role of the booster, but who may need more priming after a certain amount of time to keep them well protected.
Thank you for that. And I just would just concur with what Commissioner Jayapal was saying in terms of the policy. I think it's important, as we know, especially as we're looking at globally and the lack of vaccination access in the continent of Africa or different places around the world where they have very low access to vaccine and very low vaccination rates because of that. and we're talking here about like whether boosters are actually medically necessary and medically, advised, to do that for the majority of population. I think like it's a really important topic. So thanks for all this information on the vaccines. I'm sure we'll have more questions later.
Commissioner Stigman.
Thank you, Chair. Thank you, Dr. Vines, Jessica, and Lisa for being here. It seems like a weekly basis. Really appreciate. And Dr. Vines, let me congratulate you on being a woman of influence, and how proud and lucky we are to have you leading our public health. So I did have a question, and I know that I had sent some information, and thank you so much, about a doctor talking about monoclonal antibody treatment. Could you explain that to me?
Yes, and thank you, Commissioner Stigman, and thank you for putting me in touch with Dr. Rocco. We remain in touch, which is very exciting. So monoclonal antibodies are a therapy it's basically a serum that you can get through an IV, or you can even get it just as an injection under your skin. It's a serum of antibodies dedicated to fighting the COVID-19 virus. And so right now it's recommended for people who are early in their infection, so someone who's just tested positive, but who is at risk for going on to have severe COVID, so they can get preventive antibodies to lower their risk. It can also be used for someone who is exposed, who is not yet infected, but who similarly is at risk of going on to have severe COVID. And if they get this serum quickly, it will lower their chances of being hospitalized. So there's a lot of excitement about this therapy as a way of lowering the burden on hospitals. The rough numbers are that you have to treat about 20 people or so to prevent one hospitalization, which is not bad if you can get it up and running at scale. We have been a bit challenged by this, mostly because of staffing, to be frank, and also because the timing piece, so that the sooner you do it, the better. And then finally, for those who are already infected with COVID, you have to find a place that has all the necessary precautions around infection control and making sure that you're not putting your staff or other patients at risk. So that was all slowly coming together when we heard about a shortage at the federal level of unknown duration. But that was disappointing because we've been led to believe that there was a very robust supply of monoclonal antibodies. Now we're hearing that it's going to be on allocation to states. I think that has to do with national demand, especially in states that are harder hit than Oregon. So we're still waiting to get a clear line of sight on supply. So we haven't stopped our planning, but I think we'll be reassured to continue with the energy in planning once we feel like supply is set to come back and be there for us.
Well, that's amazing. I'm excited that we have yet another tool. So thank you so much for explaining that to me. I wonder if you could speak. I guess I have a lot of people have a lot of concerns, but obviously we have winter coming, and we've got the Delta variant. Do we see other variants on the horizon? Can you talk about that?
I can. So so the next variant, the next Greek letter is the Mu variant. This is out of South America. It's been detected across the country, but Delta remains dominant. Delta is the virus right now in the United States. Some people think that a couple things. Some people think that it can't get much worse than a Delta variant in terms of how infectious it is and how relatively severe it is. So some people think, if we can get through Delta, we're probably in good shape. Others think that any future variants may be grandfathered by Delta, that it would have to come from Delta because it's so dominant. My general sense of the landscape is, I can think back to May and June of this year, knowing that Delta was kind of out there and people were talking about it. There's a little bit of talk about the next variant, but it's not the same. So I don't feel like there's something now like waiting, in line. And once we get through Delta, there's going to be something else. That said, as with all things COVID, things can change quickly, and we are on a planet with billions of people and plenty of virus circulating and having the chance to change. But as of this moment, there's nothing on the horizon as far as I can see.
Well, that's relatively good news. And just to throw another wrench in it, can you talk about, with the potential of the flu and the importance of getting, the convergence of COVID and flu and lack of the flu vaccine, or, the importance of getting it?
Yeah, thank you for the chance to talk about this. Right, so we're heading into our typical respiratory season and flu season in particular. Pre-COVID, a bad flu season was enough to squeeze our hospitals, so we remain very interested in preventing serious flu, and by far the best way to do that is flu vaccine. Flu vaccine is recommended for everyone aged 6 months and over. It can be given at the same time as the COVID vaccine, and it's going to be really important, I think, because our hospitals have survived so far. They will get through this surge, and then they will enter what is normally a busy period on the calendar. So we can all do our part by getting vaccinated. And rest assured, I certainly want anyone in my family needing high level healthcare anytime soon, knowing how strained our health systems are. So flu seasons are unpredictable. It was almost non-existent last year because of COVID precautions. But we don't know what it's going to look like this year with kids back in school, people returning to work, and people just generally mixing more. So we absolutely urge flu vaccine age 6 months and over. As far as we're hearing, there's plenty of supply. It's never too early or too late to get it.
Thank you, Dr. Vines. Y'all get a flu shot. Thank you.
Thank you. I have a quick question. How are we, and I was going to ask you this last week and I just totally spaced. How are we tracking the third dose? Is it goes into the same system? Okay.
Yes. So third doses for immunosuppressed and potentially eventually booster doses go into the state immunization database like any other vaccine.
So in the data, data that you show to us, will you at some point have a column for, because we talk about people that have had one fully vaccinated, and then will we have another one for people who've had a third dose?
That's a great question, Chair. I hadn't thought that far ahead, but I don't see why we wouldn't be able to bring you back some of that data.
Thank you. All right, we can move on to the next slide. Thanks, Dr. Vines.
Thank you. This is Jessica again. I'll pick up with the vaccine numbers. So just a little bit to preface the slides we're going to look at. I appreciate all the questions. And as I said, we're in another planning pivot where we are looking at many of the things that Dr. Vines talked about, including boosters, looking at the information that comes out this week regarding the efficacy of boosters, and then, of course, looking at the efficacy and safety of pediatric vaccines. So right now, we're doing very active planning around what does that pivot look like. I'm sure many of you have experienced bringing a child in for a vaccine, and that whole kind of planning is very different than adult vaccines. So we're starting to look at taking a step back and what is our role going to be. So just want you all to know that strategic planning is happening. We're also overlaying the flu vaccine with that planning as well for the very reason, Commissioner Stegman, that you were asking. How is this going to factor in, particularly as it relates to pressures on our hospital and healthcare systems? So knowing that we're planning for that all together. The other thing I just want to mention is last time we were in front of you, I talked about the Swiss cheese approach, and I realized I didn't actually explain what that was and made some assumptions. So when we say the Swiss cheese approach, we are referring to multiple interventions that have to be stacked in order to cover the holes on one slice of cheese. So if you imagine Swiss cheese with holes in it, it has holes in different places, but when you layer them, this hopefully one slice of cheese captures one of the holes that the other slice has. And so for this particular conversation about the vaccine efficacy study that our incredible CD-EPI team did, and big kudos to them, it's amazing to have this data locally to really understand what's happening, to inform our policy decisions. The other piece that I want to mention around that is that's why masking is still so important. So the vaccines can save your life, and they are very efficacious, and we need to continue to mask. And that's one of the reasons why that combination approach is really what is going to carry us through this. So just want to emphasize that, and I'm grateful that you all have taken leadership on the masking policy. So with that, we'll go to the next slide. So this is our kind of meta view of where we're at with Multnomah County. We're still making progress. Vaccination uptake has slowed down overall, but we are seeing gains in BIPOC communities, which is really where we've been focusing our efforts. So if you look at our numbers overall there in the left-hand side of the slide, you can see that we have close to 600,000 people at some point in their dosage for any of the three vaccines. So we're still progressing, but just at a slower rate. We can see the gap change in populations that we talked a little bit about when we were in front of you for the budget modification. We are seeing good progress being made as we've overlaid the incentive program to the vaccination clinics. I was out at IRC, pleased to see a steady stream of people accessing services out there. I know this past Saturday at Fabric Depot, we had a very busy vaccine clinic. So kudos to our staff that continue to work through now even rain. The rain is coming back. We had rain on Saturday, but we had folks out there doing the work. So big kudos to them. Next slide. So these are the raw numbers using the rarest race methodology from the state. And just to give you a percentage viewpoint of what we're seeing across different populations, in Multnomah County total, not just with what public health is doing, but our total population, we have about 99% of our Native Hawaiian Pacific Islander community vaccinated, 67% of our Asian communities, 73% of white communities, 58% of Black, 61% of American Indian, Native American, and 56% of Latinx communities. So that's across all vaccination sites, not just public health. That's at community level. So again, we still have some work to do, but we're starting to see those gaps close with all of the focus that we have been really paying attention to and doing outreach specifically to BIPOC communities. Next slide. So, and then this is just another view of our numbers. We've received over 150,000 different three vaccines. About 127,000 have been redistributed to reach high-risk individuals through partner agencies. We've had a total of 293 vaccine clinics, 137 of which have been specific to BIPOC communities. And we continue to edge above 70% of all of our vaccine clinics reaching BIPOC communities. Next slide. And with that, unless you want to take questions now about any of the vaccination efforts, I can turn it over to Lisa for a little bit about what we're seeing with schools.
Let's go through schools and then we'll have time for questions at the end.
Okay, turning it over to Lisa Ferguson.
Thank you, Jessica. Hello, Chair and Commissioners. My name is Lisa Ferguson. I am the Communicable Disease Manager for the Health Department. And I'm going to be talking today about the work that we've been doing with schools leading up to the school year, and then what we're seeing since school has started. Next slide, please. So for quite a while, we have been working closely with the Multnomah Education Services District and our public school district leaders, as well as private schools in the county, to prepare for being in school and to work through, challenges and questions. I also want to just mention that, we have a long history of working closely with our schools in our communicable disease department. We have this is not new work to us. The scale is new to us, but we have certainly seen pertussis outbreaks, varicella outbreaks, flu, measles, and so we have a long-standing relationship with MESD and our school districts around communicable diseases. But since the pandemic, obviously volume has been higher, and we've been working closely to make sure that we have good protocols and procedures in place. And we really took the information that we had from hybrid and when in-person learning started in the spring to be able to take that data and information, as well as national data and information, to think through our recommendations and plan carefully what we were recommending to the schools to do for this school year. We in Multnomah County are very fortunate in our COVID response to have a team that we lovingly call our FOOT team. They're our Facility Outreach and Outbreaks team. And they support our businesses, our long-term care facilities, our other healthcare facilities, schools, our shelters, our correctional facilities. So they're working really, really hard to control the spread, to make sure our outbreaks stay small and are prevented when possible. So they do amazing work. And we have a special group in that team that is focusing specifically on schools. And so we've been working with the schools routinely through the summer and with MESD to develop some recommendations. Next slide, please. So we wanted to provide public health recommendations to the schools so that they had really concrete ways to think about how they could limit the spread in schools. And so we have taken our local data, we've taken national data, we've talked through different scenarios and really gotten down to what do we recommend. And then we take the information and we talk with the schools and we see, here's our recommendation, what's realistic for you to implement, what are ways that you can make sure you're actually able to protect students and staff. So we have provided recommendations around masking. One thing we've spent a lot of time talking about is meal times. Lunch has been a big concern because we know that students are often in tighter spaces and they're taking their masks off to eat and drink. We ended up making some recommendations around outdoor lunches, and we have seen the schools work really hard to implement that and encourage outdoor eating. We have heard about schools who are, painting circles outside so that students know where to eat and stay spaced enough apart. So we really see some creative work to take our recommendations and implement them. Exclude somebody, how people can stay as protected as possible while they're able to still engage in those extracurricular and athletic events. We've talked a lot about after-school programming, making sure we have good communication with the other folks who are utilizing schools and participating in those after-school programs. And then transportation is also another area with buses. We really look carefully at what's happening on buses as well, and working with what is realistic as far as staffing and the school's abilities to monitor what's happening on buses. Next slide, please. So I want to talk a little bit about what actually happens when there's a case that has been in a school, just to highlight a little bit about all the work that goes into it and to make sure that it's clear, what the process is. So when somebody who goes to a school, whether it's a staff or a student, is diagnosed with COVID-19, there are two ways that could be identified. The parent or the staff member may call the school and say, I've been diagnosed, my child has been diagnosed with COVID-19. There is also a legal mechanism that all cases in Multnomah County are required to be reported to the health department. Typically, that's as electronic lab report. So we may also receive the case report that way and make the connection to the school when our team calls to interview the family. Typically, most of the notifications that we receive are parent notifications to the school. And one of the reasons for that is that parents often have that information sooner than we have that information because of the time it takes us to get their positive lab result. So a parent calls, they let the school know that their child has been tested positive. And so then we work to identify, the school and MESD nurses will kind of figure out when was that student in class. And we look at when did their symptoms start, when do we think that they were infectious, and we determine, okay, these are the days they were in class when they might have been infectious. And then the MESD nurse talks directly to the school to determine what can the teacher say about what was happening in the class? Do they feel like masks are consistently worn? Did this particular student have a hard time with distancing, so that we can identify if there's any higher risk exposures or if we need to look at excluding a cohort because we can't identify close contacts. So as you can imagine, that can be time consuming to get to that level of detail and talk to all of the different people who might know that information. So it is challenging, but we are working really hard to get to that level of detail so that we can keep more kids in school and really only have those kids staying at home who we think are truly exposed. Once we do identify any exposures that have happened in the school or on a bus or in an extracurricular activity, there's individual notification to anyone who has been exposed. There's a letter that's sent, and many of the schools are trying very hard to do individual phone call notifications to parents for anyone who's had an exposure. But as you can imagine, that is challenging when it's hard to narrow down and there are hundreds of kids exposed. But they do receive a letter. And then there's also typically a school community letter to let the school community know there's been an exposure. And so then those children who are exposed would stay at home for that 10-day quarantine unless they're fully vaccinated, and then they can provide their records to the school or let the school know their child is fully vaccinated, and those children would not have to quarantine if they're fully vaccinated. And so Multnomah County Health Department, I mentioned our foot team. And so that team also then, if we do identify links between cases, so we might say, well, we have a case in this cohort, now we have a second case in this cohort. What do we know about those? Do we think that that might have been transmission in a classroom? And if we identify multiple cases in a cohort, then we would open an outbreak. And that's where our team then starts really looking at what's happening and where we might say, do we need to exclude more people to limit spread? Do we need to put additional control measures in place? And then we're sort of monitoring what that looks like and trying to limit spread of any outbreaks. Next slide, please. So now I just want to talk a little bit about what we're actually seeing so far this school year, now that we're a few weeks into school. So we have had, I think one of the things that's critical to know is any number I tell you is probably already out of date. Things are happening so quickly and we're getting notifications quickly. And so when we provide numbers, I looked this morning, yesterday it was around 100, and now I'd say it's probably more like 110 that we have had cases identified that had some kind of exposure on a public or private school in Multnomah County. And around, I can also say that we've had around over 1,000 people identified as exposed, but not all of those people are necessarily quarantined if they're able to show that they are fully vaccinated. What I can say is that we're seeing very little evidence of transmission so far related to school activities. We do have several situations where there are multiple cases in a cohort, and that we are really looking at possible school spread, but those are very limited, under 5 situations right now that we're aware of. And so, I think this tells us we have a lot of kids. We have I think over 100,000 kids in Multnomah County schools. And so we do see that many schools are operating safely, are working really hard to have these mitigation measures in place. And at this time are doing so pretty successfully. But again, we're watching very closely, keeping a really close eye on what's happening. We also are seeing some of those larger quarantine numbers are situations like a bus where we weren't able to identify, there was not a seating chart in place. We couldn't say that consistent masking was happening. And so there may be more children excluded than who are truly exposed. And that's what we're trying to limit. So we're working really hard to limit that. And I think that was my last slide for schools. Thanks.
Thank you, Lisa, and thanks, team, for your presentation this morning. All right, commissioners, that was a lot, as always. So now it's time for questions. We'll start with Commissioner Stegman.
Thank you, Chair. Thank you so much, Lisa. Obviously, we all know that Reynolds is on distance learning. So I'm wondering if you can talk a little bit about there. I have a lot of questions. Maybe I'll just ask them all and you can put together a response. So I'm wondering about the seating charts on the buses. So if you were on a bus and you were at the front of the bus and somebody at the back of the bus, even if you had a seating chart, I'm just trying to figure out what is the importance of seating charts, and does that really help us if you're on a bus, or is just everyone on the bus exposed?
Yeah, I think, as Jessica was talking about with the Swiss cheese, layered mitigation is always the best. And so when we're talking about an environment like a bus, what we want to see is if we can have a seating chart and have some idea that kids are staying in those seats so that we know generally where everybody is. And we also know that those kids have masks on. And we also know that some of the windows are open to improve ventilation, then we can feel pretty good that we have layered mitigation. And then we can say, okay, we know that these children were in their seats for the most part. I think that is where the challenges come in, because we do hear about staffing, as we know, and we know that we have bus driver shortages, and so expecting a bus driver to be able to pay attention to those details while they're safely driving the bus, I think is where some of the challenges come in. So I think the seating charts can help to say we have a plan for where these children are sitting. We can say for the most part they were where they were supposed to be. And then we can draw a line around, say, student A who was in the second row, 6 feet around that, any child who was in that area, we would say should be quarantined. I think, we certainly make exceptions and have so far this school year when we hear concerns like, well, I actually know that the kids in the class have a really hard time keeping their masks on, and the teacher's saying, I just don't feel good about that. Then we say, we should exclude the cohort. That's why we have those conversations, to make those decisions. So I think we also have to be realistic about what we can accomplish with, the staff and the adults supervising that we have. So I think it's always kind of walking a fine line too.
Thanks,
Thank
Lisa.
you.
And I'll just jump in. Oh, I'm sorry. I was going to answer the question about Reynolds.
Yes, please.
Okay, great. Thanks, Commissioner. So, yes, so Reynolds High School closed last week for 2 days to prepare for at least a week of online learning. That was an operational decision by school leadership, and that was because they had so many students, about a third of their student population that had been exposed. They ran into 2 problems. The first was just the sheer number of notifications to get through in a timely way. The second, and more important, was not having enough staff to do both in person for 2/3 of the school and then online for 1/3 of the school. So this was as relayed to me by Reynolds school leadership. So that was a functional, operational decision. It's not because it was not a public health intervention. There's no huge outbreak at Reynolds. This is not a public health intervention to try to slow spread in that school. It was purely based on staffing, and we heard about it from school leadership.
I appreciate that, Dr. Vines, because I know that there was a lot of kind of confusion. And I think it's important to delineate when it is a school district's decision or a public health decision. And obviously, I know you all work in partnership with them. So I appreciate that. I did have another question. So if you're fully vaccinated and you're a youth and you're exposed, then what I heard you all saying is that you don't have to quarantine. But I guess that I'm not quite understanding that, because then I've also heard in the past that you can still be a carrier even though you're vaccinated. So I'm just trying to true up those 2 issues. Can you speak to that?
So I'll jump in a little bit, and then Lisa. Just as I probably sound like a broken record, but I just want to Lisa emphasized this a little bit. But one of our goals is it's not only to mitigate the spread, obviously, of COVID in schools, but it is also to minimize any disruption to education. So the better we are at keeping kids in school, we'll reach that goal of keeping kids in school. But that is going to require a layered approach. So again, as Lisa mentioned, our emphasis on vaccinations obviously is still there. We're pushing hard. We're actually going to be out at Reynolds doing some vaccination clinics this week to increase uptake among students and faculty, but also continuing to emphasize the consistent use of masks and all of the public health measures we provided guidance on, like detailed seating charts, because as Lisa said, that helps us minimize the amount of people who then have to quarantine. Sorry, Lisa, I think you were going to jump in.
Yeah, I was just going to respond about that people who are fully vaccinated not needing to quarantine. And that's actually a general recommendation, not just for school students. That's part of CDC guidelines and the state guidelines that we follow. And it, essentially what the guidelines say is that if you're fully vaccinated and you're exposed, you don't need to automatically quarantine, but they do recommend that you get tested between day 3 and 5, and that if you have any symptoms at all, that you do stay at home and make sure you get tested. So, there are definitely some recommendations around that, and we ask people to be very cautious, but it is a general recommendation that people do not have to quarantine if they're fully vaccinated.
Great. I really appreciate that. I just think that, in a lot of people's minds, there's a little bit of confusion. So I really appreciate you all clarifying that. And also wanted to thank all of you, because my understanding, especially at Reynolds, but at many of our student healthcare centers, that not only can the youth, if you're whatever, 15 and above, can get vaccinated, but so can that family. Is that correct?
That is correct.
Great. So I really appreciate that there's just continual opportunities for people to receive the vaccine, and not just those youth, but their entire families at our healthcare centers. Thank you.
Commissioner Vicki Peterson.
Thank you, Chair. Thank you so much. I love that literally any question we throw at you guys, you guys have an answer for it. I really appreciate that. I had a question probably for Jessica from the last section, the one before schools, about how many vaccines are we getting per week now?
You mean in terms of our inventory?
Yeah, like if our inventory.
I'd have to check. I don't know our actual intake off the top of my head. I'd have to check, but I can easily find out.
Okay, yeah, I was just curious. I mean, obviously the numbers have gone down, but we're still getting good uptake in our clinics. And I think the work that we're doing with the BIPOC community is fantastic. I was just curious about what it looks like, like currently where we are in the pandemic. So I had a question then going back to the schools. So I had a couple of, at least one email from constituents around the OHA mask recommendations in preschool settings. And their concern was like, why is this a recommendation? Why isn't this a requirement? So can you talk a little bit about why this would be a recommendation versus a requirement when we are requiring masks for other school kids? Or should it be a requirement?
I don't know that I have particular insight on that one in terms of the differentiation. I suspect, and Jen, weigh in if you have other information. I suspect it has to do with the consistency in which that can be maintained for the age group. Jen, do you have any other thoughts on that?
Yeah, my wheels are turning quickly. I believe the state indoor mask mandate is for 5 and over. Same for K through 12. And so that makes just the age group in preschool and childcare outside of the requirement and in the realm of recommendation.
Okay. I mean, like as a best practice, right? Like the recommendations for anybody 2 and up to be wearing masks anytime they're possible. I just, as we're looking at childcare settings and as we're looking at preschool settings, with kids in classrooms, I hope that, we're also doing outreach and work with those in those settings to talk about like the best practices. In addition to the K through 12 schools, it's so funny. Like I'm always surprised at how adaptable kids are in terms of wearing masks and just wearing it and just like, it's a matter of course. And for all the and we hear so many grownups who don't want to be wearing their masks, but honestly, like the kids have been great about making this their just new normal. And so I think it's one of the best things that we can do is have good practices for the kids. So thank you for that. The other question I had was around, we're talking about, and Lisa, thank you for all your great information. You were talking a little bit about the 10-day quarantine and what triggers that, in the different environments. What is that 10-day quarantine looking like for kids? Is there consistency across schools or school districts in terms of like the kids' experience? Are they staying home? without access to distance learning or without access to schools. Do we have an idea about what that experience looks like for kids?
I don't know, Jessica, if you want to weigh in on any of this. I mean, I think I don't know a lot of detail about the instructional. I think you're asking about instructional. Yeah, I think it varies among district and school. I think we have certainly had conversations around encouraging access to that, but I don't think that I necessarily, in my role as communicable disease, have a strong sense for, how it varies among the districts around the instruction. So Jessica, I don't know if you want to weigh in on that.
Yeah, it's definitely something that the districts are struggling with. Case in point at Reynolds. I mean, it's a tipping point around staffing to maintain both. It's not our sort of bailiwick around, the maintaining of that. I know that OHA and ODE have strongly advised all districts to be prepared to pivot to distance learning. But I think, depending on the jurisdiction, that means different things to different people, right down to the school level. But in our role, that's why we literally are talking to the schools and MESD on a daily basis to understand what's going on and refine our approach, because we know it's a balancing act. We have two public health goals here, right? It's prevent the spread of COVID-19, minimize hospitalization and hospital overload, but then also keep kids in classroom time for a variety of reasons, not just educational, emotional, and social. So all of those things we're refining our approach to. So I feel like we've done a really good job in helping to flex so that the schools can meet those multiple needs. But I think it would be important to talk directly to the school districts around their approach to that, because I know it's a lot to deal with operationally.
And could I jump in here as well? This is Jen Vines, health officer. I wanted to link back to Commissioner Stegman's question about the Reynolds closure and this question about quarantine to just share how much we have struggled with the idea of a public health school closure, because we can keep kids out of school, but kids will need childcare. They'll get together with their friends. They're going to go somewhere. So we can talk about quarantine in the hopes that people stay home on symptom watch for 2 weeks, which is a long time. But I think when we talk about a public health school closure, we end up wrestling with, are they really any better off not in school, so not learning, not in a structured environment with, masking expectations, good ventilation, all those other prevention things. So I just wanted to share how much we've struggled with what is that threshold for a public health recommended school closure, because it may not achieve our goal of slowing spread, knowing that kids are going to gather or go for childcare outside of school.
So thank you all so much, and I appreciate it is like that fine balance, and I appreciate all the work that's going into working with the school districts and trying to find like what's the best methods to making sure that we're keeping the kids home from a public health perspective that need to be there to help prevent the spread, and then also doing what we can to ensure as many as should be in school are in school. I think it's such a fine balance right now, and I know, like, from my own kids' school's experience, like the struggle and the balance that they've had with trying to figure out what does it look like if there is, what's that tipping point, what's that number, when can they provide it, because it is a struggle to provide both the distance learning and the in-person learning with just a regular school staff. So thanks so much for answering those questions.
And Commissioner Vega-Peterson, one of our staff, thank you, Aaron, messaged me while we were speaking. We're ordering about 700 vials of vaccination every 2 to 3 weeks between public health and our clinical services.
All right, thank you, Jessica.
Commissioner Jayapal. And I just, the folks on the call have to jump off for a press avail. So if you don't have your, all the questions answered, please send them to our office and we'll get them answered. Go ahead.
Right. Thank you. I want to echo Commissioner Vega-Peterson's last point about this information is so useful to understanding all of the balancing that has to go into the policy decisions and understanding that there aren't bright lines, that every decision, whether to send a child home or to close a school has sort of countervailing factors that have to be taken into account. I think it's important for people to understand that, because people are looking for that bright line and it's important to understand that it doesn't exist and why it doesn't exist. Kind of along those lines, I guess the one question, could you talk more about the difference and distinction between exposure and outbreak? Because from some of what I hear out there, when folks hear exposure, I think they immediately go to outbreak. And if you look at the numbers of exposures, they might feel like, oh, that's a lot of stuff that's happening. But from what I'm hearing, the risks that we've seen so far are relatively low. And some of that has to do with the fact that exposure is not an outbreak. Could you talk a little bit more about that?
Yeah, sure. I can explain that. So we define an exposure. Well, I'll start by saying typically an outbreak is defined as 2 or more cases, in a common, setting time. And so usually we don't talk about outbreaks until we see at least 2 cases. And so the exposure is a student comes to their 2nd grade class and starts to feel unwell that day. They go home, their parent takes them for test, they're positive. And we usually say for COVID, 2 days before your test is or 2 days before your symptom onset is when you are infectious. And so we would say, okay, the 2 days before that child started feeling sick, they were in school, they might have exposed anyone else that they were within 6 feet for 15 minutes or more. And so that's when we do that defining. And so we might identify that that student, had 5 people on the bus that were within 6 feet. And that student also has some lunch buddies that the teacher, feels like they sit pretty close to. They maybe they didn't have that distance between them. And so anyone that we say meets that definition of 15 minutes, 6 feet or less for 15 minutes or more, is exposed. And so you're exposed. That means you could have come into contact with the virus. It doesn't mean you definitely did. It doesn't mean that you're definitely going to get sick, but it means we think where you were in that place and time puts you at high enough risk that we think you should stay home until we can say, okay, you've made it through the whole time that you might have gotten sick, and either you did and now you stay home to feel better, or you didn't and it's okay to come back. We generally see, I think last school year, we exclusively were doing cohort exclusion. It was, we were new at this and we really felt like we needed to be safe and smart and keep more kids at home. And we saw very, very little transmission among those kids who were exposed at school, but maybe didn't meet that full exposure definition. We're trying to be a little tighter about it this year. And so we think we might see sometimes where, okay, those kids, we think they were close to each other and they actually were. And now that kid is also sick. And then when we see that, oh, that's an outbreak because those 2 kids, we think they were together around the same time in the same place and exposed each other. And so then we start looking really closely to make sure there aren't more kids in that class who are also exposed or becoming sick as that continues. So we expect to see a lot more exposures than we actually expect to see cases and even fewer actual outbreaks. So I hope that was a clear explanation.
That was great. That was really perfect. And then just one follow-up question. What about testing? So for example, if a child is advised to be told to quarantine, parent gets a test comes back negative, are they then able to come back or not? And if not, why not?
Yeah, it's a great question. So, there in general, according to CDC guidelines, there is sort of an option to test at day 5 to 7 and leave your quarantine early. In Multnomah County, we generally have not recommended that because, we have felt like, particularly in schools, we have felt as though not everyone has access to that testing in that way. And we were concerned about the equity that might cause some students to not be able to come back earlier when other students could. We're really trying to look at that and kind of flip that and say, how can we make sure more people have access to testing so that everyone can have that opportunity and be able to offer that earlier test out option. So it's definitely something we're looking at. And I think, there are some avenues through the schools. The state has some options set up for people to opt into testing if their school opts into screening. Some schools have testing options, but I think we want to see more and more easy availability of testing so that we can then say to anyone who does have to quarantine, go ahead and get that day 5 to 7 test. Here's all your options for how you can do that. So I think that is the ideal that we're working towards.
That's great. That's really good to hear, because yes, it becomes, if we can make it accessible, it becomes another way to minimize that out of school time. So thank you all. Really appreciate it.
Commissioner Myron?
Thank you. I first wanted to echo the appreciation that Jessica shared at the beginning, talking about the ERCO vaccination site she was at. I was actually at ERCO on Friday administering vaccines, and it was amazing. It was like, I want to particularly shout out Christine. She was sort of the person that was organizing and keeping everything going, but Multnomah County staff and also the ERCO staff were incredible. It was like a well-oiled machine. There were so many people. It was just a beautiful thing. And so I wanted to call that out and express my appreciation. And in terms of vaccinations, it's the question I always bring up. So I just want to know where we may be in the conversation, or if we're having the conversation still with the state about requiring vaccinations to be able to use certain, we're going to get to a point where it's too late to do it, which I am afraid of, that we could potentially have to go to a situation of closing indoor facilities rather than sort of this mitigation strategy, being able to use certain indoor facilities if you're vaccinated and can show verification. So are we still having that conversation? And if so, where are we at with that? And how are we considering doing it as a county if the state is not acting?
I'll jump in and then let Jessica follow up. I've asked the public health team to do some research into this for us. They're looking at the other cities and jurisdictions around the country who have implemented one. And one thing just right off the bat that we found is that they all have some kind of app or something on their, easily accessible to folks. We have been in conversations with the state, because what would be, most effective and most efficient is if there was something at the state level, so that we wouldn't have to be app developers ourselves. And so that is occurring. But I've also asked our staff to look at just all the questions and all the structure that goes along with that. And hopefully we will have some information from that soon.
Yeah,
That's
I don't
great.
think sorry.
Oh, go ahead.
I don't think I have much more to add. It's just, I would say that, obviously looking at efficacy, implementation, and then equity. So these sorts of systems where you're verifying anything, we want to take a careful look at equity applications.
Absolutely. But as part of the equity consideration, I would also point to the fact that we do, as we are always elevating here, we have the disproportionate impact of all of this on our BIPOC communities. And so in terms of the safety and improving access, like we want to make the vaccines as available as possible, so we don't have that negative equity impact on our BIPOC communities, but looking at the health disparities as well, and the disproportionate impact of COVID on the communities, that these would be potential safety measures to decrease that health disparity. And I know there are lots of groups that do apps. I think I forwarded one on to the public health department, and so hopefully that's not a huge barrier, because there are so many. And again, it's like with the state regularly, if they're not doing it, at what point do we do that? So hopefully that will be forthcoming soon, some information about that. And then moving on to the school questions, and I appreciate my fellow commissioners' questions. They asked some that I already had, but I was just wanting to get back again to that question of surveillance testing at schools and the what we are recommending with regard to that, given the significant funding that I had understood was available from the state for schools that opt into doing that, and that I was wondering if we are recommending that our schools opt into doing that, and how that could play out. It doesn't work if it's just people who have symptoms, because by that time it's too late. It should be a screening program. Is that available, and are we recommending that?
So there is, thank you for the question, Commissioner. There is an available program through the state that PPS as a school district has opted into. And then I would have to check which other schools and districts have opted into it, but it's a screening program. And so, and they have a partnership with OHSU for the screening program. So every week, a school can opt in, and then families in that school opt in. And so you sign a paper saying, yes, I want to opt into this. Each week, you get a test kit from the school. The child brings it home, they swab their nose, they bring it back the next day, it gets sent to OHSU, and then the parent gets an email on the registered email address with the test result. And that happens weekly. I think it's Wednesdays. And so right now they're starting the sign up process. The paperwork's going out through PPS. And then again, it's a school or school district opt in to that. And then families of that school can opt in themselves. So that's the current screening testing that's available through the state. And then of course there's the Binax, that if somebody's symptomatic while they're on site, then they can get the Binax testing. There's also a program for unvaccinated staff to do home testing as well.
And I'm just going to have to jump in here. These folks have to jump off the call. I'm sorry, I sent it. So if Commissioner Myron, if you have one more quick question, otherwise, if you have other questions, just send them to us and we'll pass them on after.
Yep. And I believe that I'm just curious about going back to the concrete recommendations for public health. I mean, there are a couple of things. And so, yeah, I'm sorry that I'm at the end and just got the one question in with a short other one. I can just forward my additional questions, which have to do about notification to parents and any recommendations we have there. There's so much confusion out there. I hear from fellow parents, I hear from constituents, and no one understands how that process is really occurring, who gets notified when, and whether we have recommendations about that, and or whether that's purely a school district decision. And you can get back to me on these and I'll follow up with them. The other question is about recommendations for indoor school and the type of ventilation that is there and filtering, et cetera. And finally, if we have a way of tracking whether the concentric circles out from students, whether family members are getting sick or becoming positive from COVID, if their student, if their child is. And those will be my questions, and I can follow up with them afterwards. But have a good press.
Can I ask one clarifying question of your questions, just so that when I respond? So on the question around who gets notified, are you referring to classroom versus whole school versus individual contacts like that? That's what you're, okay.
Yeah, sort of, well, yeah, sort of a class. Yeah, I think just clarifying how it's determined who, if you're sitting at a group of desks, do all the kids get notified, but not the classroom or that kind of thing? Yeah.
Okay. I'll be happy to respond to the questions.
Thank you so much.
Thank you all. Public health. go forth and educate the rest of the world, not just us lucky ones here on this call. Thank you so much. Our next briefing this morning that we have is on the Multnomah County Sheriff's Office and Trimet IGA status. There he is, Mr. Sheriff. The floor is yours. Mike Reese, Multnomah County Sheriff. Nicole Morrissey O'Donnell, Multnomah County Undersheriff. Welcome.
Chair Kafori and Commissioners, thank you very much. It's a pleasure to be here this morning. And as you noted, with me today to help in this important presentation is Undersheriff Nicole Morrissey O'Donnell and Trimet executives Marla Blagg and John Gardner. And they're going to share with you an informational briefing on the intergovernmental agreement that we have with our strategic partners at Trimet. So with that, we'll start the PowerPoint and I will turn it over to Undersheriff Nicole Morrissey O'Donnell.
Good morning. We can go ahead and go to the next slide. Good morning, Chair Kafori and Board of County Commissioners. For the record, I'm Undersheriff Nicole Morrissey O'Donnell, and I greatly appreciate the opportunity to share our work over the last several months. Before we get started, I would also like to welcome Captain Brent Lejeune as our Chief of Transit Police, as Travis Goldberg has moved into his new role as Chief of Police for Gresham Police Department. Brent has been assigned to the Transit Police Division for the last couple of years and brings a significant amount of experience to his new leadership role. As we navigated the implementation of MCSO leading the Transit Police Division, we immediately began building collaborative relationships with Trimet to ensure a successful transition. In the spring of 2021, our proven commitment to providing exemplary public safety services was highlighted and recognized in the successful approval of the intergovernmental agreement. To ensure MCSO values are in alignment with community expectations and the values of Trimet, we referenced our recently finalized strategic plan and worked alongside MCSO's Equity and Inclusion Manager and Trimet's Transit Equity Department and Senior Community Engagement Specialist to align our vision. We began creating collaborative partnerships within Trimet and Transit Police by providing training, engagement opportunities with staff from multiple areas of the organization, and we focused on diversity, equity, and inclusion, creating a safe, welcoming, and equitable transportation system for everyone, and ensuring a shared awareness and value of addressing the reimagined public safety initiatives. I would now like to turn it over to Marla Blagg to talk more about our collaborative partnership. Next slide, please.
Thank you, Undersheriff. Good morning, Chair Kafori and the Commissioners. For the record, I am Marla Blagg and I'm pleased to be here this morning. As Multnomah County Sheriff's Office and Trimet joined forces at our new public safety building, we focused our efforts on better aligning work products. Dedicated teams were quickly formed to address logistics, technology, data sharing, and assets. The development of two plans, a communication and strategic plan, details the communication notification process and the framework of how Transit Police Division works to provide services to Trimet. Trimet is proud of our new public safety facility. The vision and nature of the workspace needed to change from where we were. We wanted to enhance the benefit of a community feel by sharing the Trimet vision in a bright, airy, and collaborative work environment. We wanted to promote the community connectivity with the community room for meetings and trainings, but abide by the strict requirements of police work. The bright open space promotes communication across disciplines, while the glazing of windows provides privacy and safety to the occupants. The common break room area allows for informal discussions and gatherings. The building is equipped with state-of-the-art technology to share information and connect staff across the 3 counties. So by design, the Public Safety Office breaks down physical communication barriers while promoting engagement, collaborative problem solving, and sharing of information. Partner relationships have also been a joint focus as well, including collaboration, multiple system partners, including including the Senior Community Engagement Specialist and Equity and Inclusion Manager. Next slide. Trimet and Sheriff's Office have been proud of some early successes. Under Sheriff Mauricio O'Donnell and I will share some of those successes with you. I've been asked by many people, what is the biggest difference about this leadership model? The answer is collaborative safety presence. While the concept seems simple, the process to create a program is complex by nature, but reap huge rewards, not only for our employees, our riders, but the neighboring community. Engaging and training all front-facing employees to be part of a solution by utilizing resources more effectively to resolve issues at the lowest level. This requires training, data sharing, education, and collaboration to recognize the most appropriate resource for an incident response. We are enhancing our system presence by the use of non-sworn safety, security, and Trimet personnel for rider engagement. Such personnel that you will see on the system are road and rail supervisors, customer safety supervisors, ride guides, and our new pilot program, Safety Response Team. The primary responsibilities of the Safety Response Team members will include engaging the riders and employees to connect riders to wraparound services. The goals of the Safety Response Team is to address quality of life issues our riders may be experiencing, decrease the calls for service currently being directed to police and other emergency service personnel, and to provide a high visibility presence to ensure the system is safe, secure, and welcoming for all. Let me turn this back over to you, Under Sheriff, to discuss our other successes.
Thank you, Marla. So as we look at some of the other successes around our collaborative safety presence specific to transit police, our bike patrol program has allowed transit police members to be more visible and accessible to community members. They have the ability to connect to a greater number of community members and provide information and education about system and other services. In addressing an area around the Reimagine Public Safety initiatives, our transit police leadership, along with members assigned to our community partnership unit, participated in a 12-week equity and inclusion learning pilot training program. And this was created by our equity and inclusion manager, Rebecca Sanchez. The content included cultural humility, active listening, and trauma-informed response. This training was delivered in a scaffolded learning approach to encourage the development of additional skills along the way and to serve the community through a more equitable and inclusive lens. We are currently working with Rebecca Sanchez and Trimet to develop a similar curriculum for transit police division officers and deputies, as well as Trimet staff. To date, 50% of our transit police division members have completed crisis intervention specialist training, which is in addition to the 40-hour prerequisite crisis intervention that many of our deputies have already participated in. So again, it's building upon some of those skills that they have already learned through other training opportunities with the organization. We also participate in a joint training effort where MCSO training unit staff have been instructing the mental health first aid classes to Trimet employees. This training focuses on an action plan to assess, intervene, and provide appropriate care and service to an individual experiencing a mental health or substance use issue. This training provides baseline information regarding risk factors and warning signs of mental illness and addiction. And it's expressed from the students that leave the training that they have a better understanding of the impact of mental illness and addiction in their work, family, and their community. To build upon mental health first aid, Transit Police Division members, along with the Department of Public Safety Standards and Training, have also begun to offer lunch learning sessions for Trimet employees. These opportunities are offered to discuss previous incidents and provide additional education tools and strategies to address current challenges as well as to answer general questions. This opportunity is offered virtually. That ensures less contact during COVID-19, but it also allows for increased accessibility to Trimet personnel. This encourages, again, that building of relationships across the system, and it enhances our communication between Transit Police and Trimet. We also continue partnering with our HOPE team, who is most recognized for providing compassionate outreach first approach to connecting individuals on the system to services. as well as offering housing and behavioral health resources. And in addition to our Hope Team model, we're exploring opportunities to partner with Gresham Police Department, with their mental health team and neighborhood response teams, as well as we're always interested in learning about other agency models that may fit within our vision and goals. We are very proud of the accomplishments that we have currently made, but we are absolutely eager to continue to build upon this work. And now I would like to turn it over to John Gardner to talk about the Public Safety Advisory Committee.
Thanks, Nicole. Good morning, Chair and Commissioners. I just want to make sure you can hear me okay.
Good morning. We can hear you.
Excellent. Well, thank you again for letting me update you all on our Reimagine efforts and our work to recruit and launch our new Reimagine Public Safety Advisory Committee. As you know, the committee represents just one of many strategies and ideas gathered from the community outreach efforts last fall that we've been working to implement. First, a little bit more on our recruitment efforts to establish the committee. Over the last 4 months, we reached out to over 200 community-based organizations, social service providers, and partner staff across the Tri-County area about the committee and the opportunity. We connected with hundreds of contacts through our low-income fare partner list and the Oregon Health Authority. We received recruitment input from TIAC and our Committee on Accessible Transportation, and we also recruited through our monthly Equity on a Move newsletter, with recruitment stories posted over 3 months, going out to about 600 community program staff. And finally, we leveraged regional Facebook and Twitter outreach and advertising and promoted on Facebook groups in Tualatin, Tigard, and Gresham in English and in Spanish. And although summer is a notoriously hard time to connect with folks, we are happy to say that we have over 16 organizations and individuals prepared to help us continue the work of Reimagine, with our first meeting kicking off next week. At this point, the committee consists of 5 community representatives from Multnomah County, 5 from Clackamas County, and 6 from Washington County. The committee is made up of experts from the field of social and human services, houseless services, youth services, cultural specific community services, mental health and addiction services, higher education, community advocacy, and the senior and disability continuum. And all of our community members are focused on working with our team to make the region's public transit system more safe and welcoming. You get a sense of some of the membership on the bottom of the page there. Next slide, please. I think there was some questions around the difference between the Reimagine Public Safety Advisory Committee and our current Transit Equity Advisory Committee, TIAC. So from our lens, the Reimagine Public Safety Advisory Committee is just one more representation of our commitment to community engagement and ensuring there's a forum to discuss important public transit-related issues. In addition to the new monthly Reimagine meeting, TIAC will continue to meet. TIAC stands for Trimet's Transit Equity Advisory Committee. Like our Public Safety Advisory Committee, TIAC consists of community-based organizations, transit advocacy groups, or culturally specific comprehensive service providers from across the Tri-County service area. TIAC's primary role is to provide insight and guidance to Trimet's leadership and the general manager on issues of equity and access. TIAC's meetings provide a forum for the review and discussion of Trimet's annual service planning and our Title VI and Civil Rights Program, ongoing safety and security efforts, our organizational workforce diversity and hiring efforts, our construction projects and workforce and minority contractor utilization, our community engagement initiatives, and our approach and our fare subsidy programs. In addition, TIAC also consistently recommends strategies and ideas for improved service, especially to transit-dependent populations. And in turn, the 17 TIAC community-based organization partners assist in sharing Trimet updates and information to the communities they serve. And although there is a small amount of overlap when it comes to public safety, I've found that when it comes to community engagement, a little bit of overlap is a good thing. Now I'll hand it back to Nicole, and thank you.
Thank you. We can move to the next slide. We'll now shift our presentation today to highlight the foundational work that we have accomplished, including creating lines of communication, technical connection between our data systems, identifying metrics, and designing regular reporting mechanisms. We recognize that everyone is looking forward to hearing about data reports and examining crime reducing and safety increasing strategies. And we are absolutely as well. However, a successful and seamless transition into leading essentially a small police department has been a big lift. Our priority has been transit operations for our first priority, putting in place the resources and personnel that allow MCSO to deliver the services the community expects. And this has been and will continue to be a tremendous effort, though one we are absolutely honored to lead. Our next priority has been data, and it's not any less challenging. To have a full picture of transit policing, we must receive data from approximately 13 jurisdictions, each with their own records management systems. Even with our collaboration within our own Multnomah County partners, this will require new data use agreements, processes, and procedures. However, we do look forward to speaking to you about the results of these efforts in this coming spring. We have been successful in receiving data on a quarterly basis that includes dispatched and self-initiated calls for service, which has guided our initial efforts. When evaluating our progress, successes, and challenges, we began to measure our impact through the system by focusing on the core function of our work, by addressing where and when we receive dispatched calls for service and how quickly we respond to those calls. Holding ourselves accountable to the public to ensure we are responding to emergency and non-emergency calls for service in line with community expectations, while also providing Trimet riders and operators peace of mind in a safe system is our top priority. In collaboration with Trimet and Transit Police leadership, MCSO's Planning and Research Unit, and partner agency analysts, a quarterly report has been designed. This report includes system-wide dispatched calls for service at Trimet locations and also focuses in on the top 5 calls for service and top 5 locations. Self-initiated activity of the Transit Police Division, which includes the most frequent call types and locations, average response time to calls, and average time spent on calls at Trimet locations, including both emergency and non-emergency calls, and Transit Police presence or time actually on the system. Next slide, please. While calls for service data paints an informative picture of our work on the Trimet system, equally important is the data on reported crimes. MCSO regularly utilizes trends in reporting crimes to drive resource deployment in patrol areas. And I believe you are all familiar with the crime density maps that we've frequently used in community discussions regarding public safety. Unlike calls for service, the vast majority of which can be accessed through our Bureau of Emergency Communications, crime data generally resides in the records management system of the jurisdiction in which the crime is reported. So what this means is that a full picture of transit-related reported crime requires data from 13 different systems and an integration so we can begin working through the data use agreements that don't currently exist in our system right now. While we are taking steps toward making this integration a reality, we want to be forthright that such an effort is time-consuming and largely contingent on the willingness of our other regional partners. But again, we look forward to discussing our progress at our upcoming briefings. Next slide, please. Our goal is to have a positive interaction with everyone we contact. This involves spending dedicated time on the Trimet system and using that time in part to connect people with resources that help meet their needs. For those with the greatest need, those without housing or in need of assistance with behavioral health resources, we are invested in providing services and utilizing an outreach-first approach rather than continuing the cycle of justice involvement. We are currently developing a process to collect information on outreach services offered, provided, and if accepted by an individual. Ensuring that we are developing a process to provide services or a connection to services, as well as measurables to assess our progress, is also in alignment with MCSO's strategic plan. We also look forward to working with our health department partner that is in progress, which will assist with outcome information with service providers. As we continue to expand our data footprint, we're currently working on developing collaborative efforts between MCSO's Planning and Research Unit, other agency analysts through those data use agreements, and Trimet's analysts, as some critical information is not reported through dispatch, and that could include incidents that are reported through Trimet's accident incident database or community surveys, safety surveys, which also assist in informing the most appropriate resources and services that are deployed on the system. Next slide, please. As we continue to look forward, we are evaluating training opportunities that are in alignment with community expectations and reimagined public safety initiatives. And we're in the process of identifying an equity and inclusion training experience model that can be more broadly delivered to a greater number of staff. We are also continuing to connect with our system partners to share Trimet and transit police updates to create alignment within the Tri-County region. As we are looking at ways to better utilize personnel across the system, we will take this opportunity to discuss the positive work that is occurring and encourage new partnerships, including sharing and learning about innovative service models that other agencies may be utilizing. An example is our partnership with Washington County to develop the mental health response team model, which you will hear about in December. We're also working collaboratively with Trimet on a strategic plan scope of work that will assist in guiding our work with Trimet, and anticipate that this will be finalized by the end of the year. So much of our work throughout the last several months has been focused on building relationships throughout the system and understanding the roles and responsibilities of each entity, sworn and non-sworn. As positive relationships have been built and we all have a shared awareness of the services and resources on the system, there's opportunity to more effectively collaborate and decrease any overlap of services, as well as fill any gaps that we recognize along the way. So we are invested in working together to provide a safe and equitable transportation system for everyone and continuing to listen and learn from our community. I will now turn it back over to the sheriff. Next slide, please.
I'd like to thank Trimet and specifically John and Marla for joining us today and for their willingness to partner with us, and to our undersheriff for the presentation, and again, welcoming our new captain, Lejour, who's not with us today on the screen, but is hard at work at the Transit Police Division. So, you know, again, our goal is to create shared values across our public safety system with Trimet, and to encourage and support a safe and welcoming transit system. We've been busy this summer and in the spring in a lot of community activities. You can see some of those pictured here, where our transit staff are out and about in our community, serving and building relationships. At this time, we'd like to open it up for any questions that you have. Of course, we'll be back in December with an additional briefing on the status of our outreach and engagement models in partnership with the health department.
Thanks, everyone, for your presentation today. Questions and comments from commissioners. We'll start this time with Commissioner Myron.
Thank you. Thanks to all of you for that presentation. It was really